Hi, everybody. Welcome. This is the Combating the Opioid Epidemic Policy and Program Solutions panel, so hopefully you're all in the correct room. My name is Pamela Greenberg, and I'm the President and CEO of the Association for Behavioral Health and Wellness. ABHW represents payers that manage mental health and addiction, and we serve about 170, or represent about 175 million covered lives through our association. Today, we have three panelists that will be speaking each for about 10 minutes, and then we will open it up to questions and answers and discussion. So, as Mary Ann said, we really want to try to create a dialogue. So even if you have a statement, something that you're doing, it doesn't have to actually even be a question. We welcome learning from you as well as you learning from us. Uh-oh, I just switched something, but we're not going to worry about that. So our panelists today, our first panelist is Dr. Brad Lucas, and he's the Senior Medical Director of Buckeye Health Plan. And then he's providing really how they're treating opioid in one plan, what they're doing, treating the opioid epidemic. And then we're going to move to a broader scale with Dr. Ross Hoffman, who is the Chief Medical Officer for Envolve Health and Envolve Pharmacy Solutions. And then we're going to switch gears completely and go to my colleague, Rebecca Klein, who's the Director of Government Affairs at ABHW. And she's going to give you a little update on what's going on in Washington as it relates to the opioid epidemic. And so we'll save the questions at least until after the three of them speak. I might ask them one to kick it off, and then we'll move on to you. Do you want to switch this back, Mary Ann?
Yes. Good to go?
Yep.
Thanks, Pamela. Thanks, everybody. Brad Lucas, going to give a little bit of the community, local health plan, state perspective on the opioid epidemic and some of the things that we've been doing. One of my roles over the years, a lot of years of working with Centene and Buckeye in the medical director capacity, was to work, I'm an OBGYN, was to work with our care managers across the country and help identify the ways to help members who are pregnant and challenged with different medical behavioral problems. And we would have phone calls and we'd talk this through, and it really never failed that we would reach a member somewhere, pick a state, who was obviously really challenged with addiction and a lot of things going on behind that, but the addiction was really at the forefront. And it was, although we were all well-intentioned, well-meaning, kind of know this population through work we'd done in the past, it was almost a habit. We would kind of move on with the idea we don't know that we're tasked to do this or have the resources or are supposed to, or are able to. Let's move to somebody with gestational diabetes or hypertension or behavioral health problems and see how we can help them at that time. And it really became apparent as we saw the number of babies going in for neonatal care because of neonatal abstinence syndrome and the toll that it was taking on our members and communities. Ohio has a big infant mortality effort going on, as that's a big problem also. And it became really apparent to all of us at about the same time. We got to take this on. We want to take it on, and there wasn't really any argument at any level in the company to start to approach that. This was in 2013, and those of you who are familiar with building a story or building a program, often you really need to understand what's going on. And we were working with one of our providers, a hospital in Toledo at the time, and said, well, what's going on in Toledo? And we started to look at our neonatal abstinence rate there. And I could establish that through all the way through October of 2013, and if I went back to 2009, the number of babies, the diagnosis of babies getting neonatal care had gone up 937% over that time. And then we saw that elsewhere, obviously. So it was very easy to substantiate why we're going to move forward. And I know, I'm certain everybody here understands the depth of the problem, the numbers. Probably everybody has some own personal stories, so I'm not going to touch on that. But that was the one that really got us going. So what did we do? We know that through medical claims, pharmacy claims, we could start to understand a lot about our population, is what you need to do when you build a program. Using different cuts and looks at our claims data, we could see how much it was affecting our members at some point in their lifetime, where we had claims data, at some point in the past year, the last 60 days, the last 30 days. And based on what we were seeing, we started to set up what our outreach program was going to be. We spent a lot of time getting out and really knowing the champions, the experts in the field across Ohio. We're lucky to have some really good ones, learn from them. Reached out more and more to understand the providers out there who are caring for those who are challenged with addiction. Put that program together. A big part of the program was integrated care through our behavioral health care managers and our OB care managers. We're lucky enough to have good ones on each side, so everybody that was approached, identified, and offered help, they had that. So you're kind of going back and forth, a team effort to help things there. Coordinating care, attaching members to services is huge. Sometimes I think that you hear coordinated care and it becomes such a word that you've heard so many times that it doesn't mean quite as much. But when there's people genuinely knowing how to take really good care of people with addiction and understand the medicines that people need, our members just don't show up at their doors, and these facilities don't know how to go. They don't go out and get them. And these aren't people that often are ready to be found. But finding them, speaking with them, and attaching them to these services is huge, and we've started to become good at that at a state level. So a lot of it connecting to services, removing or reducing prior authorization requirements around Medicaid-assisted therapy, providing transportation to counseling sessions, Narcotics Anonymous, to the clinicians, all sorts of transportation. For a while now, we've provided pre-programmed cell phones and cell phone minutes to help our members, again, connect to support and family. We made sure those were available. Diapers, cribs, pack and plays. We have a pretty good knowledge of what our members need, especially when you're at this point in your life, and just really being there for them. A group of people in Medicaid, we're pretty non-judgmental as it is, and we don't really have those barriers to provide care that's needed. But probably my favorite story from all this was, we thought it would be really difficult, and it was, but in ways it was less difficult than we thought it would be, because when we did reach out or touch base, or people learned to reach out to us, they hadn't communicated, had any support, any dialogue with anybody in years. They'd really broken their bridges with their family and their friends. The only people left in their lives were people who were just bad people who were helping their problems. So to have that door be, I always described it as, we're going to make sure people know the door is open and let them come in, and we're going to really, really support them. So that got more and more involved with task forces at county levels, a number of task forces that we were involved with, got involved with the drug courts. A housemate of mine in college is a judge in Cuyahoga County who makes a lot of determination on the future lives of people who've gotten into crime because of this, and really helping him understand what are the services how can we help with some of his decision making on what are the other options that are out there. So it's been a very successful program. We measure certainly the birth weights of the babies, how many babies are admitted for neonatal care, how long those babies stay there. I think it's really important. We want to know how many people are enrolled in our program stay there through delivery, and then how many people are still in the program about a year later. It's been interesting. We've had more than 300 people go through the program. As we were exploring and learning about what was happening out there at the time, there was also a lot of standardization of how to take care of the babies in the neonatal units. And the average length of stay as we were exploring this was going from 50 to 20 based on the use of medications. We knew in Ohio it was around a 20-day stay. Pretty quickly we had that down to a 15-day stay, 13-day stay, and now it's a 7 to 9-day stay on average for babies admitted with neonatal abstinence syndrome. I make sure we don't claim all of that. A lot of doctors providing really, really good care. So those are some of the metrics that we look at, and I think I will stop there and hope maybe I can address any other questions, or lots of lessons learned, and it's been a good path.
Good afternoon. So my name's Ross Hoffman. I'm Chief Medical Officer for Envolve Pharmacy Solutions, and thanks for being here during siesta time. Appreciate it. It's a nice fall day, so you could be elsewhere. But we have a crisis on our hands, and so I think everybody in here knows that, and we're all motivated to find the answers. I don't think that anyone in particular has an answer from, the highest offices in our nation down to the folks in the communities who are struggling with this in their lives every day. So I'd like to say thanks to MHPA for giving us this opportunity to discuss this critical matter. I'm a cardiologist. I've been one for so many years, and a husband and a father to 4 kids, and a youth athletic coach, and a community member. And I've got a persona at Centene and Envolve as well, which is a fantastic position, which gives us an opportunity to really touch a lot of lives. So, and with this crisis on our hands, I think it's an interesting opportunity to think about healthcare overall, and one area, one domain in particular. It's possible that what we learn about fixing this may be translated into fixing much of what is ailing healthcare today. At least that's my hope. So let me tell you just a little bit about Envolve and Centene, because I think it helps set the context for what we do. So Envolve Health is wholly owned by Centene Corporation and provides supplemental affordable health benefits and specialty services. And Envolve Pharmacy Solutions is the pharmacy group within Envolve Health. So we're a specialty company. We're a large pharmacy benefit manager, PBM. We have about 9 million covered lives and process around 100 million pharmacy claims annually. And as Brad has alluded to, we all are part of a larger organization, and we have the opportunity to think, particularly as fellow physicians, to think about problems in a holistic, patient-centered way, where our minds are not wired to think about pharmacy claims or medical claims, but more to identify problems with people, patients, members, and their families, and then to try to build solutions around that. And so that's the lens that we look at things through. Envolve Pharmacy Solutions also has a specialty pharmacy, which is Acaria Health. And Acaria Health has a national footprint and about 30,000 patients on census on a monthly basis. And I'll touch on that a little bit more, because I think specialty pharmacy can play a particularly interesting role to help gap fill in our health system, which has some challenges around integration. So solving the opioid crisis requires a multifaceted approach, and which includes prevention. It requires pharmacy management, education, and cooperation with a wide variety of stakeholders: law enforcement, behavioral medicine, policymakers, legislators, and work with trade organizations such as MHPA. While our approach starts with pharmacy, we are also addressing in this process some of the care delivery issues that touch on treatment and recovery. So there's a lot of work ahead, but I'd like to tell you a little bit about what we've done and what we're doing. So we'll cover medical policy, prevention, and treatment. Concerning health policy, we work in collaboration with task forces. So this is really a great marriage between the plans, where our plans are working on task forces down into the states. So in my position, I sit on task forces with some of the national health plan organizations, and then also with pharmacy trade organizations. So we exchange information. We try to build consensus around how we should inform policymakers at the states and in our country to get to the best answer in the shortest period of time. So it's really important work. We also participate in roundtable discussions with CMS, including some recently over the last few weeks, where they're convening folks from the plans and the PBMs, asking us for our insights in how we can tackle this together. And I'm also pleased to announce today that we'll be working in collaboration with other plans as well, with a nonprofit organization, Shatterproof. This is a group singularly focused on the addiction crisis. And if you're not familiar with them, you can find them on shatterproof.org. I think you'll be moved. I am, and which is why I mention it. Prevention. We prevent addiction by improving prescribing patterns, and some of that's been discussed, I think, in some other sessions here. I'll touch on that a little bit more detail and also give you some numbers as far as outcomes. I don't want to throw a ton of numbers here, but I want it to be clear that there is work to be done, but there's also work that has been done, and it's measurable. We also prevent death by facilitating access to opioid blockers and resuscitating agents, naloxone in particular. And so we work with pharmacy networks along those lines, as many PBMs do. We have 65,000 pharmacies in our network. And so we have the opportunity to partner with our plans and create joint messaging, and also to encourage fulfillment of naloxone, which I'll mention I think is still an opportunity to fulfill more naloxone than is being distributed today. And that's based upon our analysis of claims fulfillment. And third is treatment. Through our specialty pharmacy at Carrier Health and in cooperation with the health plans, we deliver MAT, medication-assisted therapy. And there are a variety of medication-assisted therapies. Some of them are opioid replacement, some of them are opioid blocker. And so we're doing actually a good amount of work around both in really trying to optimize, including opioid blocking in helping to promote opioid-free survival. And we are also in the process of integrating behavioral health into these services so that we can address the primary root causes of addiction, in addition to treating with symptom and craving modifying agents. So a little bit about what we do at the pharmacy level. So we'll limit days supply for opioid naive users, limit maximum dose, and we also have a step through requiring immediate release before long-acting agents. And of course, we have exceptions to these for appropriate patients based upon state-specific mandates. Some of our results, looking at 2015 to 2017 year-to-date, when we look at total number of members utilizing opioids for greater than 30 days, year on year, we've reduced that number by anywhere from 14 to 30%. Then we look at total opioid utilizers. That number has decreased 10 to 15% year on year for the same time frame. And similarly, same time frame, total number of opioid prescriptions have been reduced 15 to 20%. So with regard to the opioid naive population, we're making progress. And I should mention there's a very nice CDC graph, you can find it on the CDC site, which demonstrates something that I think is important for us all to recognize, which is that the rate of opioid prescribing has plateaued when you look at those national data sets. And I think that there's a lot of cooks in the kitchen on that one, as far as staking claim to what's happening. And I think that it's really a call to action to say, well, where are we going next? So there's lots of attention being paid on this issue, which is good. We have more to do there, but we need to keep going. So we're making progress, but there's more to do. As far as exceptions, we do provide exceptions for special needs populations such as palliative care, oncology care, and diseases such as sickle cell. I want to talk for just 1 or 2 more minutes on a couple of issues, perhaps outlier management. So one of the benefits that we have in working so closely with plans and working as part of a larger organization is we have access to very large data sets and data scientists and statisticians and PhD kind of real brainiacs who love to crunch numbers and speak with folks like us who like to think about clinical problems and sort of, come up with algorithms to try to gain insights and figure out what patterns are developing and how we might intervene. So we actually spent a good amount of time working on those kinds of things and then informing our plans and our members and other partners as to what we might do to intervene. So what I mean by that is we're able to identify use, abuse, misuse patterns. And so we can look at members who are going to multiple pharmacies or multiple physicians. We can crunch those down further as we drill down and look at subsets of members with various clinical diagnoses or combinations of drugs or trends in combinations of drugs or trends in frequency of ER utilization or combinations of any one of those things and then target those folks. We're also doing the same thing with prescribers. So I grew up in the world of Rocky Mountain HMO back in the day in Western Colorado where we shared data openly, and we had in the doctor's lounge what was affectionately referred to as the wall of shame, and you didn't want your name at the top of the wall of shame. You were an outlier for some reason, and I mention that because we policed ourselves, and this is really an important opportunity, I think, to engage the providers as opposed to putting upon them and sharing data in a manner. And John Doerr mentioned this earlier today that if we can commingle the data and present it in a way that's digestible and valid and accurate, because docs don't like when the data is not accurate, trust me. But if we can do that, then I think we can also model even better prescribing patterns. And we'll also gain insights because we need a virtuous loop there. We need feedback on that. And so last thing I'll mention is on the prescriber profiling side is I think there's lots of opportunity for improvement there, and we are building dashboards internally so that we can share across our enterprise. So those are some of the things that we've done, some of the things we're doing, and I'll pause there in the interest of time so we can address others with questions. Thank you.
So I'm going to talk about some of the things that the administration and Congress are working on now to help fight the opioid crisis at a national level. The first, as you probably know, is the public health emergency that President Trump announced last week. A couple of months ago, you may remember President Trump said he would issue a national state emergency on the opioid crisis. So we waited a couple of months, and last week he changed course a bit and directed acting HHS Secretary Hargan to officially declare the opioid crisis a public health emergency. A public health emergency differs slightly from a national emergency. In one way is that the public health emergency must be renewed every 90 days. This specific declaration would allow for some existing grant money to be used to combat opioid misuse, permit the hiring of specialists to tackle the crisis, and expand the use of telemedicine services, particularly in rural areas where we're seeing a real shortage of providers. There was no commitment for additional funding associated with this emergency, and the fund that is associated with public health emergencies is actually empty at this time. So a national emergency would have gone farther in allowing the federal officials to access a pool of funding through FEMA. So funding for this crisis may be something that could be addressed legislatively at the end of the year, and I'll talk more about that in a moment. But I'm hearing and reading that the White House is asking Congress to consider funding, and they, I think, recognize that that's a really big part to this public health emergency. Another thing that happened during the president's announcement of the public health emergency last week is that he said that the administration would lift the IMD exclusion, which is a rule that prohibits the use of Medicaid funding for care provided to patients between the ages of 21 and 65 in mental health and substance use disorder residential treatment facilities that have more than 16 beds. So this is a pretty pricey thing to turn around. So the fact that he acknowledged that he would make that change is pretty great. And we at ABHW are supportive of making that change and look forward to seeing what that would look like. And I'll just emphasize again that funding will be very important to this crisis, and just putting out a public health emergency is a good step, but it's a small step, and there's a lot more that still needs to be done. So another thing that the administration is working on is the President's Commission on Combating Drug Addiction and the Opioid Crisis. In March, the President wrote an executive order that would establish this commission that is studying ways to combat and treat the crisis. A draft report was released over the summer, and one of the top issues that was mentioned or recommended in that report was to declare the crisis a national emergency. So there was a little bit of follow-up with that, with the public health emergency. A final report is expected from the commission this Wednesday. So we are anticipating that report and expect that it will include many, if not all, of the recommendations that were in the draft report. Some of those things include mandating prescriber education initiatives, establishing and funding a federal incentive to enhance access to medication-assisted treatment, providing model legislation for states to allow naloxone dispensing via standing orders, providing federal funding and technical support to states to enhance interstate data sharing through prescription drug monitoring programs, or PDMPs, better aligning substance use disorder privacy regulations with HIPAA, and continuing to enforce the Mental Health Parity and Addiction Equity Act. While the report may include some or all of those recommendations, it is just that. It's a report of recommendations, and it will be up to the President to make decisions on how to delegate and move forward with those recommendations if he chooses to accept them. ABHW recently spoke at an opioid commission listening session at the White House, and some of our top recommendations were included in the draft, and some of the things we mentioned included aligning substance use disorder privacy regulations with HIPAA, and I'll talk more about that in a moment, reforming PDMPs, easing the burden on primary care providers willing to prescribe medication-assisted treatment, requiring evidence-based care in accordance with national standards, and expanding access to telehealth services. Another issue that ABHW has asked the Commission to investigate is fraudulent treatment providers. We've seen a dramatic increase in the number of fraudulent substance use treatment providers in the past few years, mostly with sober homes and residential facilities. These facilities are often unlicensed, and we see them taking advantage of patients who are in serious need of treatment. We at ABHW met with the Energy and Commerce Committee in the House of Representatives recently to discuss this issue. It seems to be a top priority for them, so it is possible that this could be something that may be addressed legislatively at some point as well. Another thing to note about the commission is while we were at this commission listening session a couple of weeks ago, Governor Christie, who is the chair of the commission, suggested that there would be a call to action for insurance companies, or some sort of ask or demand on insurance companies. So that's something to just sort of flag, and something that we will obviously be keeping our eye on to see what exactly that might look like, and how we'll take that and move forward. The third thing I want to talk about is legislative opportunities. As you might remember, last year, Congress passed the Comprehensive Addiction and Recovery Act, or CARA. This bipartisan legislation passed both houses of Congress, and President Obama signed it into law. It would improve access to overdose treatment, create opioid overdose reversal medication access and education grant programs, include an evidence-based prescription opioid and heroin treatment and interventions demonstration, expand the availability of MAT for recovery from addiction, improve treatment for pregnant and postpartum women, and authorize HHS to award grants to states. So this bill authorized over $180 million to address the crisis, but that money was not appropriated. It needs to be appropriated by Congress every year, and a small amount of money was appropriated last year specifically, and in order to really be effective and to be the helpful tool that it was meant to be, the money really does need to be appropriated on an annual basis. We are hearing that the House of Representatives is considering a larger opioid package at the end of this year, and we expect and hope that funding would be included in that. I don't have specific details on what would be included in that package, but we would of course like to see the issues that I've discussed so far, also telehealth and other ways to address the workforce shortage, a creation of a national prescription drug monitoring program. And to give you an idea of there are many small opioid bills that have been introduced during this Congress. It's obviously an issue that affects every congressional district, and every member is trying to figure out what a solution could look like. So there are many small standalone bills. Some of those, I'll just give you a sample of what some of those look like. There are things like imposing an excise tax on opioid manufacturers, establishing additional registration requirements for prescribers of opioids, authorizing SAMHSA to award grants to states to expand access to opioid use disorder services, mandating compliance with certain prescription drug monitoring programs, and of course, there's always asks for more funding for the epidemic. There is one particular bill that I wanted to highlight as something that ABHW has been very supportive of and was instrumental in getting introduced, which is about amending substance use disorder privacy regulations. This is also known as 42 CFR Part 2, or Part 2. For a bit of background on that issue, in case you're not familiar, this is our member companies say that this is one of the biggest, if not the biggest challenge that they face in addressing the opioid crisis. Part 2 was created in the 70s during the Nixon administration, so about 20 years before HIPAA came into place. And it was created in order to encourage people to seek treatment without fear of being prosecuted by law enforcement, and to provide them additional protections as they were undergoing their substance use disorder treatment. And what it does is it doesn't allow for disclosures of a patient's record without their specific written consent for each provider, each individual or entity who they would like to see that information. We see this as a big challenge because without access, in an instance where we don't have a consent form from a patient, you don't have access to the patient's entire record, so you're not able to treat the whole person. So the Substance Abuse and Mental Health Services Administration went through a rulemaking process over the past, at the end of the Obama administration last year, ultimately released a final rule that made some minor changes to how that consent is collected and how you can provide a general consent, how you can redisclose or not redisclose information. And we did think that it made some minor steps forward, but it did not go far enough to what we would like to see, which is aligning Part 2 with HIPAA for the purposes of healthcare treatment, payment, and operations. Again, in order to be able to use that information in a healthcare setting only, continue to protect a patient's privacy and their records, that they're not used inappropriately, but so that we are able to treat a patient in a coordinated, safe, effective way. So we are seeking a legislative fix for that. We have legislation in the House and in the Senate that we hope to see moved, perhaps, like I mentioned, in an end-of-year opioid package. So as you can see, many steps have been taken, some small steps, some a little larger, to address the crisis, but we still think that much more needs to be done, and look forward to seeing what happens in the next couple of days with the commission report and what might come at the end of the year with a larger package.
Great, thank you. So just in the short time that we've been here, 2 people have died from an opioid overdose, just to kind of create that visual in your mind based on the statistics of how many people die every day. With that, I'm going to take the moderator's prerogative to ask the panelists a question each before I turn to you. So while I'm doing that, in addition to listening to them, if you can be thinking of something you might want to ask them as well. And I will start with Dr. Lucas. What are some of the initiatives in the past year or 2 that have impacted the epidemic, do you think, either in a positive or a negative way? And they can be state, federal, or your own health plan.
Yeah, and I forgot which question I was going to get, so that's an appropriate one. Some of the things that we are doing, coordinated services project. This has been happening in Ohio for a few years now, where the health plans we identify our members who've been using multiple sources of prescribers for opioid medications and getting them filled at multiple pharmacies. And we created a lock-in program where that member can only go to one pharmacy to have those prescriptions filled. And if you would change from health plan to health plan, that stays with you. We identify these members through pharmacy claims, medical claims. We're beginning to look at who also is using, presenting to the ED, and we know they're overutilizing opioids. We'll discuss this monthly, who belongs on that list and who doesn't. Once you're enrolled in that program, you're there for 2 years. And we've actually seen behavior change as a result of that lock-in program. That's good. It forces us to look at it. It forces people to have conversations and think about it. Another would be, we are familiar with limitations put on prescribing now, and we did this at a corporate-wide policy level. We had discussed it at a statewide level. We see it at an Ohio policy level now, where you're allowed to have 14 days of medicine in a 45-day period. There's some exclusions, and there's a 60 morphine equivalent dose per day, so it's pretty rigid. We're trying to turn off the spigot or close the people who've not been exposed to opioids going down that path where we kind of put ourselves where they're at risk of finding an addiction or that it starts with people being exposed to prescribed narcotics more than they needed, and kind of having them around the home or trading them among friends, just being available. So putting the limit on that, which is good. We want to do that. What we're seeing is as a result of this, is primary care doctors are now just wanting to be, and this has just happened, and we're seeing these effects already. Primary care doctors don't want to touch any of their patients who are on narcotics now. They want to just shut that down and divert everybody to the pain medicine doctors. Pain medicine doctors, who are probably already kind of struggling with a lot of this, are just right now saying, okay, we are overwhelmed. Just they're already, I mean, this has been just weeks, months, maybe a month that we've been doing this, and they're already overwhelmed. And so I think that's a lesson as we have to be careful at not being so reactionary and so saying, well, we got to do something and doing it without looking at the long-term consequences. We, like so many things, we got to identify where we want to be, how we want to be there as soon as possible, and remove the barriers. We can't just be reactionary. We have to. So these folks who have been on chronic opioids, it burns me up when I see a member who has just kind of chronic diseases, and they're on chronic opioids, and it's not. There probably just hasn't been the discussions that have had to happen. They probably shouldn't be on those medicines, and they're not addicted, as we would say, describe addicted, but now they may just have nowhere to go, and that's going to disrupt their lives. It's going to disrupt how they take care of their families. There's going to be a bigger effect on a lot of people than we realize there. So I guess my message is we are going to see whole new areas of treatment that need to be developed in pathways, and so that has to come. There has to be a buy-in from everybody on that.
Great, thank you. And Dr. Hoffman, I know that there were some state attorney generals who wrote to pharmacy benefit managers and asked them to, play a part or a role in helping combat the opioid epidemic. In your role and with your company, were you involved in reacting to this and responding?
Sure. In a word, yes. And this was a little over a week and a half ago. So we received a letter signed by 16 state attorneys general. And basically it was a nicely written letter indicating that they are taking this crisis seriously, and they want to reach out to PBMs. I think there were about 15 or so included, in request that we follow aggressive standards to move opioid naive prescribing to remove or reduce the number of prescriptions written. So effectively, what they stated was consistent with what we were already doing, and which was around limiting day supply dosage and step through short acting before long acting. So that was effectively what their message was. It wasn't much beyond that. They did mention some of the larger national PBMs and indicated their recognition that there seems to be a little bit of difference in approach depending upon which company is writing the policies. But that said, they were actually pretty specific in stating 7 days is what they thought was a good target, which is I think entirely consistent with CDC's publication in March of 2016. And so our response to them was to indicate to them that where we are in our program with implementations around day limit and dose limits, and also to call out to them that our policies also need to subscribe to state mandates, which, as everyone here is intimately aware, that that there are differences state by state. And I think that is an interesting point to highlight because as we are all looking for evidence-based solutions, and we're all looking for standards and guidelines, there is always a very important need for individualization based upon patient needs. Because we don't really completely understand precision medicine. We don't completely understand dose response in individuals. We'll get there with pharmacometabolomics and pharmacogenomics and so on, but that's going to take years. And so for now, we have to honor the sanctity of the patient-physician relationship. But at the same time, when we do come up with standards, it would be great to get to a point where we're operating more at the level of the way we utilize NCCN or the American College of Cardiology sorts of standards. And right now I think we're challenged in accommodating the state's needs and everyone's appropriate sense of urgency to respond by doing something, which is good. And now I think we have the opportunity to try to harmonize those steps that have been taken, and so that we can understand what emerges as the best practice.
Thank you.
You're
And
welcome.
Rebecca, you talked about the substance use privacy issue of the records. And, it's hard for me to understand, is there any opposition? Because it seems like making records available so that people can get integrated care and all of their providers know that they're being treated for an addiction. Like, does anybody oppose that?
Yeah, it seems like a common sense solution. And I think there are concerns from some patients who feel like once you open up the ability for all providers to see your information, that if too many people have access to your records, it could end up in the wrong hands. However, the legislation that we've introduced does include a provision that from the original statute that would prevent these records from being used in criminal proceedings, and it even strengthens that a little bit. And additionally, our intent behind this legislation is to maintain protections that currently exist either in HIPAA or in Part 2 regulations for patient privacy purposes. So I do think that ultimately the goals are aligned between those who have some concerns and those who believe that it's, the patient safety is number one concern, and we need to see the full record for each patient.
Great, thank you. Okay, so I've asked my questions. How about the audience? Questions for the panelists? Yes.
I think that some states are passing legislation about requiring physicians or clinicians to be trained in opioid abuse or pain management as part of their continuing education requirement. There's a lot of health plans in the room. Here's, I think, every clinician would tell you there's varying degrees of quality around continuing education credit. How would y'all propose addressing that? Whose role is it to make sure that education quality, it's useful, it's addressing the problem? Is that a useful thing to put in legislation, or are people just doing that to sell doctors stuff?
And if you can maybe repeat the question before you answer it, because I'm not sure everybody can hear.
The questions, I think, the level of requirement of continuing education for physicians in your area to be better, have the capacity to take care of members who are challenged with addiction. And this is, I'm going to answer this, and it's going to sound like I'm saying two completely opposite things. I have feedback from addictionologists in Ohio that I know really well, and they're adamant, don't put barriers in, guidelines, requirements, you got to do this, you got to do that, because more people are going to get out of that business or be hesitant to get in. It's almost like they say, we need as many people helping as possible, get them helping, and then let's kind of, keep figuring the best way to do that as opposed to putting out barriers. This is really a place, when you're dealing with something big, you got to get rid of as many barriers as possible and not put them in as you're doing it. Now, on the other side, when we start looking at this problem and looking at the immenseness of the problem, we need doctors who are comfortable, providers who are comfortable in wanting to take care of these individuals. That has to happen, and so how do you do that without having some sense that there is some things to learn, and simply to be culturally sensitive properly, but there is some learning that has to happen. So probably continuing education, make it available. I know in Cleveland, one of the hospitals right now, some of the docs, they're getting them trained and signed up there's a DEA waiver, so you can be a prescriber. They're getting doctors in there, teaching them, getting that paid for, getting it all done like on a Saturday. So I think the more ways we can find the people who want to be involved and get them trained, and not be the limitation, that's what we got to do.
I'd like to add just a comment to that. So, I agree with Brad's comments. So there's no perfect answer. Practically speaking, we have 2.5 million people who are addicted to prescription medications, and we don't have enough caretakers for them. So we need to figure that out. And that's one. And I think another fact, and this has been mentioned with regard to fraud in the substance use treatment marketplace, we have a great degree of variability in that market as far as quality is concerned. Mm-hmm. So I think that from a plan's perspective, things that we can do are to credential networks. And we are actively, particularly through the role of the specialty pharmacy, where we touch many providers. So we get a glimpse under the hood a little bit, and we can see who looks like they're practicing high quality and who might be requiring some continuing education or other enhancement to their care delivery. And I think in doing so, we have an opportunity, and we are in discussions with thought leaders from around the nation who are subject matter experts to help us in establishing credentialed networks so that we can get patients to reliable sites. On the education side, I'm a little bit torn on that. I've done some work around this in a prior life with American College of Cardiology, and love all of my doctor brethren, but we're busy, and voluntary CME just doesn't really seem to do it. And concepts like morphine dose equivalents are not things that many physicians have been trained on routinely. And so I don't fault states that, as part of your relicensure, that requires some course that gives you some training in it. Whether or not that should be linked to the kind of practice you have, I think that's going to vary case by case. But from the payer perspective, I think what we can do is to credential networks, and that will be of benefit.
And one more thing to add to that, I've heard a push around more education in medical school. So before we even get to the point of needing continuing education, and I do, now that you mentioned that, it reminds me that I think there is a piece of legislation that a member of Congress has introduced around that idea of better education in medical school to address this issue.
I just want to add to your comments that the education piece, I'm a licensed clinical social worker, and I worked for years in the addictions treatment field. And in my educational training, I had one elective course on addictions in grad school. I got all of my training on the job, and I was fortunate that I had great supervisors and got that. But I think that's the crux of the matter is we have a lot of folks out there, doctors, mid-level therapists, who are to work with addictions, but really we have no clue. So it's got to be a multi-pronged approach. I mean, in my opinion, it's all of the above, including how do we get the educational, the academic facilities engaged, and this is going to be part of healthcare for many, many years, and we need to be prepared for that.
Great, thank you. Other questions? Yes.
I wonder if we're doing enough to educate our patients. So I'm curious about pre-addiction to address the epidemic. So, for example, are we advising patients on tell your dentist I don't need 7 days of Vicodin post root canal, maybe 2 days is sufficient. Do we need to be doing more to educate the patients to be informed consumers? And one area that really is of concern is relapse. If you have, for example, a patient who goes and gets a prescription, maybe even for
Yeah.
containing cough medicine, and to ask the question, does this contain any opioids? So what should we be doing in that area?
You can go first.
Yeah, we need to change in large part how much of our primary care and our all of our docs, all of our providers, there's a whole, it's almost a whole new disease that we've got. This is a disease that we've got to screen for at all levels, talk about at all levels, to all patients, no assumptions. Everybody's got, when we screen for cancer or how healthy somebody is, if they're going to be pregnant or if they're smoking, I mean, all this should be part of pediatrics, working with families. It has to come at every spot, because that is, I mean, anytime I run across somebody who I know in my community who's going to have surgery, some kid I know, I think all the docs we're telling the parents, just make sure they don't get too many meds there. So yes.
So I would echo that. There's more that we can do through initiatives such as Choosing Wisely through the American College of Physicians and AFP. This is a topic of discussion in some of the task forces that we sit on, figuring out how we take a multi-pronged approach there. So some of it will be sort of direct to consumer kinds of information, certainly education in the schools. There's jump rope for heart in schools, right? So couldn't you do programs along those lines that sort of inform children about pain and how you manage it, and there are treatments for it, and some are safe and some are not so safe, and those sorts of initiatives. And absolutely on the provider profiling, we have started rolling out scorecards, and some of our trend analyses are pretty interesting, and we are feeding that information to the plans and showing both regionally and by specialty which specialties seem to be conforming and which seem to be lagging, and that's an interesting opportunity for focused outreach on the part of the plans with those physician groups, and then also when we have the data, at the quantity that we have, the large quantity, we're able to speak with some specialty societies as well and say, well, here's what our data is showing. What can your individual societies, ENTs, for example, dentists are a little spotty. And some of them are clearly changing their practices, and in some geographies less so. So I'd say the answer to your question is yes, and in a variety of ways.
Yes.
One of the things that I think bothers me as much as anything else is when you go to the pharmacist and you get a prescription refill for anything, and conversations that I've had, because this is something that has struck me as well. And it turns out that we have a number of different sort of regulatory hurdles to overcome, and stakeholder groups, and one of those are the boards of pharmacy and their representation. And I would say in some instances there are examples where boards of pharmacy hear what you're saying and are agreeable, and then in other cases less so. So more work.
Yes.
Have you looked at any technologies to kind of restrict or monitor medication adherence for the opioids? There's a lot of wireless devices, cards that can kind of monitor. I know today they just look to call someone in, bring in their pills, they count them, or okay, they look at your prescription, you fill it 30 days ago, you're good. But there's a lot of technologies
Absolutely. Everything from locked devices in homes, like pill ATMs, to smart pill boxes, to smart pill packs, to smart pill caps, and so the answer is yes, we are, and we haven't cracked the nut yet. There's an excellent review in the last 4 to 6 weeks, written up in, I think it was in one of the mHealth throwaways that actually was extensively referenced, talking about the results overall with those solutions. And it's there are no good answers to date, but we are, and we continue to look at more innovative solutions, such as tagged pills. And it's my belief, if we can get the cost of that platform down, then in certain special populations used for limited periods of time where we're trying to engage the member and give them sort of a remote monitor informed intervention and engagement, that we will switch their minds. I've seen that done in other disease states. Right now, I think we're just contending with the cost of the platform, but I think we'll get there.
Great, so I think it's time to conclude. Thank you all for coming, and please join me in thanking the panelists.